Hello and welcome, LabRoots users. I'm coming to you today from Tucson, Arizona, the home of Roche Tissue Diagnostics, Ventana, and the University of Arizona. My name is Tom Grogan. I'm a professor of pathology from the university and the founder of Roche Tissue Diagnostics. My field of expertise was the study of lymphoma and mainly studying what explained response to therapy and what explained failure to respond to therapy. And my experience founding Roche Ventana was that I wanted better tools than I had to understand what explained responses to therapy. Today's topic is the importance of tissue chemistry in immuno-oncology, which is coming to you on the 3rd of June. There are 4 parts to the presentation. First, we'll talk in general terms about concepts surrounding immunotherapy. And then secondly, I want to go give you a deeper dive into the clinical experience of immunotherapy by going into detail about a patient on immunotherapy. And then in the 3rd segment, I want to go beyond the one patient to a couple of population-based studies, which really bring us to what I would call the universalization of immunotherapy. And then finally, to end on where is all of this going? What may we expect next? So let's start in general terms, talking about immunotherapy. And first, really a historical point, which is in the last 50 years, the advent of effective immunotherapy is probably the biggest change, the greatest progress in the treatment of cancer. Of any other development. In fact, it's the importance of this, the understanding of it, the elucidation of the targets of immunotherapy is recognized in 2018 with a Nobel Prize, which went to James Allison and Takashi Honjo. They elaborated this phenomenon of the blockage of immune response to cancer. And that's what we're going to get into. And on the heels of that, and they had the implication from their work that blocking the blockade might solve the problem of immune inhibition. And pharma acted on that and acted in spades to produce this next generation of anti-blockade drugs. And the revelation has been that I'm calling them drugs. I mean, generally they are humanized monoclonal antibodies. The revelation has been that this may lead to restoration of immunosurveillance in a phenomenon that we could call self-healing. So let's talk for a minute about immunosurveillance. That's the aspect of your immunity which is your protective cellular response to foreign antigens. You and I are alive right now because we have this capability. It's an important part of our being in good health. It takes a very particular form in the matter of cancer cells, mutated cancer cells that produce foreign antigens. That there's a specific T cell response. It's much of the effector cell response is by CD8 T cells, and that infiltrate the tumor. And there's a characteristic immunologic definition of these cells, and there's a characteristic spatial definition. And so really what you want is to have a tumor with a very strong tumor infiltrating lymphocyte response by activated CD8 cells. And that is the desire. But where we start with is a prelude to cancer often is the loss of immunosurveillance. And there are a few of those situations that are logical. For example, you could have the HIV virus, have AIDS, you've lost your T cell capability, you will lose your ability for self-healing. And those patients in that situation may die of malignancies. It happens when you get older, that there's immunosenescence. And the Nobel Prize went for describing that there can be a molecular basis for the loss of immunosurveillance called acquired immune resistance. And the immune blockade is an understandable phenomenon that limits the physiologic response to inflammation. It has a positive physiologic definition. And the revelation was that tumor cells could take on that chemistry and block the immune response. So immune blockade, the surprise was that cancer cells could block host TIL responses to tumor antigens. That was new to medical science. And it comes down to the fact that there's a very specific chemistry. Now, there are a number of elements in the response inhibition. I'm going to focus particularly on one of those combinations, and that is when the tumor upregulates program death ligand 1 and binds to program death 1 on T cells. At the very end, I'll mention some of the other factors that are involved. But this complex of PD-L1 and PD-1 inhibits CD8 TIL activation and, amazingly, invasion. It not only makes that T cell inactive, it also immobilizes it. So if you think of CD8 cells as the wolves of the immune system, this has not only stopped the wolves from hunting, it has immobilized them. And the revelation, again, is that anti-blockade therapy, typically in the form of a humanized antibody to either PD-L1 or PD, can block the blockade and restore self-healing. So this is presented in diagrammatic form right here. And the lower left is a tumor, and the yellow antigens you would see as mutated antigens passed on the antigen to antigen processing cells, dendritic cells, trafficking to a lymph node, and stimulating a T cell response. And the product of that response are the CD8 positive cytotoxic cells that then are informed to attack the tumor. And so on the right side, we see in every step of this exchange, there's a whole chemistry to it. The one I'm going to emphasize is on the lower right, and that's when the tumor puts up a PD-L1 that promotes PD-1 on T cells and inactivates them. And this process, as shown, can be blocked with humanized monoclonal antibodies. So what we're talking about is a phenomenon called acquired immune resistance. It's not a genetic change. It's a reaction to foreign antigen. It's a rate-limiting reaction on the immune system. And it's the creation of a phenotypic force field. And we're going to come back again to this word phenotypic again. Now, so those are the general concepts we have. Let's go into the example of a patient who was treated with immunotherapy and get into some of the details about how this patient came to that immunotherapy. First of all, it's a 70-year-old male with a malignant melanoma right on the top of his head. It was deeply invasive with lymph node involvement, and it had something called satellitosis. So it was classified as a stage 3B with an 80% probability of relapse. And the fact is, with that relapse, the probability that that patient will survive it is very low. So it is a lethal circumstance. That's the bad news. The good news is on initial evaluation, we find that there is a BRAF mutation and there is an anti-BRAF drug. So maybe this can be dealt with. The example I'm relating to you comes from a book called Chasing the Invisible, which I've just published. And the subtitle is A Doctor's Quest to Abolish the Last Unseen Cancer Cell. And it's my account over these 50 years of patients in the very circumstance of the patient I'm talking about. So it's a collection of such patients. And it's also an account of how tissue chemistry and in particular immunohistochemistry really informed the treatment of these patients. So back to our patient. Our patient, you can barely make out near the middle of the screen, there are 5 or 6 little ink dots, and they're surrounding this little fleshy nodule about the size of a pea. And it turns out that is a truly nasty malignant melanoma with an 80% probability of killing this patient. It seems entirely improbable that a little bump on your skin could kill you, but that's the danger of this disease. And when you look at here at the histology in the left, you're seeing purple and pink. And that's because we're staining a section of this pea-sized tumor with hematoxylin and eosin. The hematoxylin is purple, staining the nucleic acid, and the pink is showing us the protein. And at the very top of the screen is the surface of that epidermis, and radiating down into the connective tissue are islands of primitive tumor cells with a high nucleic acid to protein content. And we think of that as a primitive, undifferentiated tumor. In fact, maybe it's a metastasis from someone else in the body. But on the right is the immunohistochemistry staining for SOX10 that shows us that this has the chemistry of melanocytes. It's derived from melanocytes. And if you look at the very top, you'll see a necklace of cells right at the epidermal boundary. Those are the normal melanocytes, and this tumor is derived then from them. So remember this SOX10 because we're going to come back to it. Now, if we further our analysis and with PCR assay look for allele-specific mutations, we find the BRAF V600E mutation, and that seems to be good news, and here's why. There is a specific anti-BRAF V600E mutation drug. And furthermore, you see in this survival curve, the top line here is showing you the benefit, the gain in progression-free survival if you're BRAF V600E positive and receive that drug versus a person who gets only the standard chemotherapy. So one thing to notice about this scale, notice the x-axis is in months. So our patient, thinking it's just a little P and no big deal, is actually facing this timing of 9 months. But for the moment, the good news is there's a mutation, there's a drug directed at that mutation. And so this is where we are. We look at it as we found a sequence which is targetable. We have a drug to affect that. We must be in and high clover here. But I'll just point out something if you go back here. Notice that although the patients with the anti-BRAF treatment do much better for a good 5 or 6 months, notice where both curves end up. So recurrence is a factor. And this becomes more apparent when we do this. We're going to take our patient and go deeper. We're going to do next-gen sequencing. And lo and behold, it's not one mutation. It's altogether 10 mutations. And this is a hypermutated state commonly associated with with melanomas of solar damage. And so we come to this point that our drug affects one of these mutations, but not the others. And it leads to this. You begin to get into this situation that Hercules was in 2,500 years ago, fighting the Hydra, which is, what does it mean if you lop off one head, right? You've got the other heads to deal with. And so this is all too often the problem, that tumors evolve genetically and there's more than one mutation involved. So let's get at the logic of this. The good news is there is a magic bullet. It is precise. There is an FDA-approved diagnostic. But the bad news is that tumors hypermutate and they evolve. And attacking it from the point of view of one mutation doesn't do it. So what are we to use? Multiple specific treatments? And then there's the fact that any of one of these agents happens to coincidentally spark other pathways. So what's our solution? Are we going to go with polypharmacy, multiple mutation-specific drugs given in a cocktail? Our cocktail would have, what, 10? Or is it possible that we take a different strategy? I'll go back to this right here. What if instead of going for the heads, what if we go for the body? What if the body has attributes in common? So is this a tenable strategy? Is there any scientific basis to thinking this way? And just bear with me for a minute. I think there's some work in this area that suggests that, yes, finding that phenotypic driver may be the key. And it goes back to this seminal paper, which is published about the genetic branched evolution. This happens to be in the circumstance of renal carcinoma. And when you read this paper, it reads very frighteningly as if we're never going to succeed one mutation at a time because of this evolution. But the paper ends, and the last statement in that paper says something very interesting. In tumor heterogeneity, there's genetic divergence with consequent phenotypic convergence, which alters cell function at the protein level. And the way I translate this is, for all those ongoing genetic changes, there comes a dominant driving force, which is a common denominator of the function of those cells. It may not be one protein driving force, but there may be a couple. And the key seems to be to get at the cell function that's involved. So let's ask the question, is there such a phenomenon occurring in our patient? Could we attack the body instead of the head? So we're going back to the patient now. Here's what we know. We know from the next-gen sequencing that this patient's tumor is hypermutated. And you can say the consequence of that is they should be hyperimmunogenic. And that, in fact, classically, those few people that survive this a really malignant melanoma, did mount a self-healing response. It's just that with that many mutations and the rapid growth of that tumor, the CD8 cells become exhausted, right? So and also the response to those mutations can be blunted by an immune blockade protein, okay, and which downregulates the T cell activation. That's another complication. So the tumor itself can cause a loss of immunosurveillance. But let's say in this patient, we find that that immune blockade protein is there, that this acquired immune resistance is operative, then we do have a whole armamentarium of relevant drugs that should promote self-healing. So let's go back to our patient now. Remember, he had a metastatic lymph node. So this was in the neck of this patient. There are 45 lymph nodes, and this was the one lymph node that had the melanoma in it. And what you're looking at is from low power in the microscope, a section of this lymph node, again stained with hematoxylin and eosin. And the paler parts of this are where the melanoma is. The dark parts are where the lymphocytes are. And what we want to look at, ask the question, is there some phenotypic property found in the pale cells that we could get at in terms of treatment, some common denominator? And particularly, we're wondering, has it put up an immune blockade we could attack? So we go to multiplexing immunohistochemistry. And what we've done is we've painted PD-L1 brown. We've painted the wolves of the immune system, CD8, green. And we've painted the T cell inactivation molecule, PD-1, red. And I call your attention to the upper left. I think it's the most obvious there. You see how some of those tumor nodules are very PD-L1 positive. They're surrounded by red PD-1 inactivated cells. And notice that the wolves of the immune system, the CD8, are mainly outside, not inside the tumor. And so this is what immune blockade looks like. This is what you get when you have intact tissue and you're studying it. You see the field of play. You see the relationship between one element and the other. And actually, this high PDL with nearby but not invasive TILs is the very circumstance in which anti-PD-1 and anti-PD-L1 drugs are the most effective. So this patient very intelligently would be treated with an anti-PD-1 or PD-L1. And so here's the patient treated with anti-PD-1, happens to be in the oncology ward at UCLA, and it happens to be me. And this is a picture taken in one of the 21 times I went to LA to get an infusion of Keytruda over a year. I had, generally, it wasn't that difficult. It was a little inconvenient flying back and forth, and there were some side effects like itchiness and blister formation and nausea and so on. But really, they were minor compared to the really scary part of this therapy was the trip on the freeway between LAX and UCLA. That was truly scary. But the other part of it went pretty well. And I had the benefit that this is in 2015. It was right at this moment in time when the dosing had been worked out. So that helped me. It also happened to be the moment in time, you may remember, when Jimmy Carter, the American president, had presented with a metastatic melanoma to the brain and liver. And he went on this same anti-PD-1. And you know that Jimmy's alive today. So it was just the beginning of understanding that immune blockade drugs could make a big difference. And so for me, so far, so good. Here's a picture of me with my immediate family, wife, daughter, son, their spouses, and my 5 grandkids. Were about to fly off into the bush in South Africa. So yeah, thanks to being well treated. Now, you can look at this patient, this circumstance, and me, and say from a scientific point of view, look, it's an antidote. It's one person, okay, you can add Jimmy Carter to it, but that's still the few. But what's really important, you don't change medicine based on a couple people that, let's say, got lucky. It's really based on taking the next step, which is how do you universalize this? How do you get it to everyone? How do you get it to every patient in this circumstance? So that's the third part of this talk we're going to talk about, which is how therapy has gone from the few to the many. And in the case, the specific, and I'm going to discuss 2 diseases here. One of them is malignant melanoma, and the other one is breast cancer. In the case of the malignant melanoma, the red letter day in which we went from the few to the many was on the 10th of May, 2018, when a population-based study with more than 1,000 patients with stage 3 melanoma in 13 countries who were treated post-resection with anti-PD-1 showed a 30% improvement in relapse-free survival. So what comes out is that this now is the new global standard. And the reason you can say that is because you're not doing this at 1 or 2 famous universities to be promulgated out from there over many years. You start by doing it on a global scale. So I think this is a very important hallmark in our immunotherapy, is its globalization. My second example of the universalization is triple-negative breast cancer immunotherapy. So if you have any familiarity with this disease, it's an uncommon form of breast cancer, but it was considered medically as uniformly fatal with a median survival of just 18 months. And the red letter day for this breakthrough immunotherapy, for this triple negative, came in November 2018, again published in the New England Journal of Medicine. And it was the demonstration that the immune blockade drug, anti-PD-L1, Tecentriq plus taxane, was a game changer. So this was a study with 945 patients, randomized and run in 200, randomized and blinded, and run in 246 locations in 41 countries. And if you were a patient receiving anti-PD-L1 whose T-TIL cells were PD-L1 positive, then your progressive-free survival was 25 months versus 15 months for the non-PD-L1 positive. And your hazard ratio was 0.62 versus 0.80. So if you know hazard ratios, 1.0 would be no gain in survival. And as you go closer to 0, there's a gain in survival. So what this trial showed is that the phenomenon of immune blockade and the anti-blockade therapy, based on the circumstance of the phenotypic properties and the immune status of this patient, had a higher probability of success. And there's a statement the very last statement in this paper is, it is important for patients' PD-L1 expression status on tumor infiltrating immune cells to be taken into consideration to inform treatment for patients with metastatic triple-negative breast cancer. And so remember, the title of this talk is The Importance of Intact Tissue Chemistry. And so that ability to see where the players are, it's not just that you had some tissue that you ground up and found PD-L1. No, it's finding the PD-L1 on the TIL. And that is the critical determinant here of the likelihood of response. There's another aspect of this study that I think is really important, and that is it was done in 41 countries, and it was done in, I say below, 945 patients in 18 months, okay? But what was absolutely unique is all these patients were essentially studied in a few months. They were given the same drugs, the latest, greatest, and then they all had the same diagnostic. It was automated immunohistochemistry with the same assay on an automated instrument. It's the automated diagnostic that allows you to produce the same result all over the globe. And this turns out to be very important in the case of triple-negative breast because it's uncommon. And if you were in a single university to try to run this study and get 945 patients, you would probably be 7 or 8 years accumulating the patients. And those patients would not have been studied at the same moment in time. But because all these patients were studied within weeks of each other, because they all had the same test with the same interpretation by the same methodology with the same drugs, then you can become very assured about your statement about what's going on. And then something else has happened, and that is, whereas the historic precedent was starting at a university and eventually making it to other countries, this started in other countries and became the global standard on day one. Okay, so I think this is what our future looks like. Just one other comment about this. There's one other oddity here, and that is this antibody SP142 particularly highlights PD-L1 on T-TIL, and it's a characteristic of that antibody. And I think it is an interesting quirk of immunology to explain, is this an isomeric form of PD-L1? I mean, what explains this oddity? But I can tell you exactly the same phenomenon has been found in urinary bladder cancer as well. So we come to the fourth part, which is the future directions. And the fact is, we don't know nearly enough. There are many more response elements than what I've been talking about. There's a lot more to this than PD-L1 and PD-1. There's a lot more of a need to predict who will respond and to monitor response. There's a study which I think I call your attention to out of Tony Ribas's lab, published in Nature in November 2014. And I think it heralds what the future looks like. And that is, he studied patients in which they did sequential biopsies, pre-treatment and during treatment. They followed the response. They followed the spatial aspect. They determined whether there was TIL invasion. They followed activation. They followed proliferation of the effector cells and whether those cells were enzymatically equipped to kill and so on. And I think that approach, which went from single analytes to multiplexing, and that giving us the possibility of monitoring treatment defines what our future looks like. So I recommend that one paper to you. Now, I think a key thing for us to understand is that we need to leave the world of one analyte at a time. I mean, we're hooked on just show me the PD-L1. But as I'm about to show you, there are more response elements, there are more cells involved, and more types of cancer to be studied. So really important in this future endeavor to enter the world of multiplexing. It's going to look more like this. So I'll show you two examples. One of them is a multiplex. Here's a 5-plex chromogenic. And this is the world we need to enter. These are in these 5 colors, from the green PD1 to the yellow macrophages to the turquoise CD8 cells, the purple, what are they, CD3, and you can make out here and there some silver stained cells. Those are the FOXP3 positive, probably the Tregs. But what's really important in our future studies is we've come to this point of a much higher capability with multiplexing. I mean, what's remarkable here is the colors don't mix. They're sharp, and they reveal the lay of the land. And remember, in what we want to do, the spatial orientation being preserved is very important. One other example, now I'll go to fluorochromes, and I'll return to metastatic melanoma. And this is, again, a 5-plex, but on the red ball you see on the left side of the slide stains with SOX10. You remember that? That's telling us that this is a melanoma. And then what you notice is this kind of bright rim around the outside. Those are the immune cells, the TIL, that, as you see, has not entered the tumor effectively. And really, there's a lot going on at that edge. And let's go to the higher magnification. And now we're seeing this not only from the point of view of PD1, which is here in, what is it in? It's green. And the CD8 is in turquoise. But notice now new elements, the LAG3 and the TIM3. And it turns out that acquired immune resistance, T-cell exhaustion, T-cell inhibition is driven by more than PD1. It's driven also by these other factors like LAG3 and TIM3. So look at where we are in 2020. Okay, so begin looking all the way over to the right where it says T-cell exhaustion. You see a CD8 cell, and look at that. It's upregulated LAG3 and TIM3 and PD1. It's exhausted. It's headed. Leave me alone. I've done enough. You're on your own. Okay. Now, preceding that, go all the way over to the left. You see the word TACE. That's transarterial chemoembolism. This is, and then HCC. This is a hepatic carcinoma that's been treated with TACE, and there's a storm of tumor antigens. And now there are two elements of the response to the storm. One of them is all of the antigen-presenting cells, like the dendritic cell, you see in just about the middle there in the light blue, stimulates T-cell response, stimulates, in essence, an inflammatory response in association with macrophages and T helper cells. And you have a CD8 response, inflammatory response, even at a distance to this. That, over time, becomes exhausted from the sheer unrelenting stimulus. And then the new part we've all come to understand is the part in the middle below, okay, in which you see the tumor cell, HCC, expressing PDL1 and blocking the CD8 cell. And now you see the interplay with Tregs and accessory presenting cells and all the other factors at play. So clearly, to understand what's going on here from the point of view of one of these markers is not sufficient. So here's my conclusion, and that is I believe that immuno-oncology and the treatment, immunotherapy, is highly informed by intact tissue chemistry. I do think it is revealed a fair amount from the point of view of single analytes, but it is nearly not enough. We need to universalize to more types of cancer, many more markers. Where do you see in the standard analysis the LAG3 and the TIM3 and the Treg status and so on? That should become part of our everyday vocabulary. And multiplexing should be absolutely what we're used to seeing every single day. And then we need to understand that a patient with malignant melanoma, a patient with triple negative breast cancer is not occurring in one country with sophisticated medical capability. It's occurring all over the world. And our goal should be to reach everyone. And I think one of the things we're learning in these studies is that's possible. And that should be our imperative, that medicine is the same all over the world. And we need to focus on predicting and monitoring as a more informed way to proceed. So that's my presentation. Thank you for your attention, and I'm happy to answer questions.